Okay, I think we're finally all set up. So this is something I did a few years ago, and Lorraine asked me to go over it again with you guys, which I think it definitely bears repeating because we don't see it very often, and we've got so many new team members. And the good suggestion we got today that we're going to add to it is we're going to do an actual practical part, like actually look at the pieces and see how it attaches to the bed and actually put the pieces in motion. So we'll start with like a 20-minute just quick presentation about what the star frame is, why we've used it, what the basic pieces are, and I'll even show you guys a few clinical cases we've used the star frame for and why I think it works so well. So, just to start with an x-ray. So, you know, even to a sort of unpracticed or untrained eye, you can see that this is not a normal pelvis. So a huge amount of energy has gone through this pelvis, and the right side, on this side here, is sort of disrupted from the rest of the body and is traveling up towards the head. And we can see that there's a big gap here at the front at the symphysis, and what you can't see in very much detail without a CT scan is that there's a big disruption in the back of the pelvis too. So this is a big injury. It's a life-threatening injury. These are some of the sickest patients that we treat in ortho trauma. And the wave of how these are treated now versus how these were treated in the 80s and the 90s is that we need to try to get this pelvis back where it belongs, both for the patient's long-term function, you know, their leg length, their ability to ambulate, their ability to sit in a balanced fashion, and for their like immediate life-saving measure. So long as their pelvis is sitting in the wrong zip code there, they're still bleeding. So this is a really bad injury. So the question is how we take this without doing a big open bloody 5-hour, 6-hour operation and get it to look like this. So put it back where it belongs, all done minimally invasive, all done with percutaneous fixation. So here's another example of a patient with a really bad bleeding problem. This is an open book pelvis. These are some of the worst ones for bleeding. And how you get that, and you make that with fairly small incisions, minimal blood loss from the surgery, and it's one of the most important and urgent interventions we do. So pelvic fractures really range in severity. We get everything from the little old lady who's fallen over and crunched down on her side rather than breaking her hip, just a little crinkle in the pelvis, right up to these big bad ones, which are some of the ones we were looking at there. So the vertically unstable ones, those ones are bad, they're difficult to reduce, they're bad for bleeding, and the open book ones that are probably the worst ones for bleeding. So those are the patients that were having the 4 long traumas with the belly open and the 18 units of blood. Those are the open book pelvic fractures. So how do we do that? Like, how does this kind of come about, and how do we, how's the evolution of how we treat things gone? So historically, the only way to get the pelvis to move, because it's not like an arm or a leg, you can't grab it with your hands or grab it with a clamp. It's deep inside the abdominal pelvic cavity. So how do you get a hold of it? So traditionally, it was really just like inexact ways to pull on the patient's leg. So with different angles, either pulling on the skin or with skeletal traction. External fixator pins in various parts of the pelvis can kind of be helpful, but again, a bit of an inexact science. The next thing that evolved was some kind of table fixation, and this was the first version that came out. A surgeon named Joel Mata, who works in the States, who did a lot of the kind of original writings about pelvic fractures, to develop this. So what this frame did was lock the patient to the table. But the frame we're going to talk about today kind of takes it one step further. So this is a picture of the star frame from the website, the sales website. So this was really kind of the next evolution. So how we can combine how all these things work and make them work together to reduce the pelvis. So essentially what this thing does is it combines all of those previous techniques. So through the table, we're going to go through how this works. We anchor, or through the frame, we anchor the patient to the table. So now the patient's fixed, so they're stuck. So now we can use those X-fix pins and traction in an organized fashion to manipulate that injured side of the pelvis. So we've got them held there so the resident's no longer pulling them off the table. And then we're using X-fix pins and traction to pull them exactly where we want it as we're watching it on X-ray. So it allows it to be really controlled. You know, another crank is coming down, another millimeter, another millimeter, another millimeter. And then once we get it, then we can hold it. And to me, that's the big deal. Because getting it where you want it was not always the hardest part. It was holding it there. Because putting those screws in the back of the pelvis can be a 90-second procedure, or it can be a 90-minute procedure, depending on the patient's anatomy and morphology and how good the x-ray views are. So to try and do that on a moving target, boy, that's tough. And it makes training really hard. So letting the fellow do that while you're pulling on the leg and things are moving around is really difficult. And what this does is it holds it there so that it really becomes a useful training tool as well. So I'll go through the step-by-step technique and then I'll just show you a few cases where we used it. So this is a picture from where I did my fellowship. You can see this tiny little old school room. But the basics are the same. So you need an OSI table. You need an abdomen that doesn't have any contrast in it. They always say no nitrous, which is kind of an old school thing in anesthesia they don't really use anymore, but nitrous gas can get into the abdominal or into the bowel walls, so it can affect the views of the pelvis as you're looking through the abdomen. Patient is always supine on the OSI table. There's always a bump under the sacrum, so people use a variety of things for that. I usually use a flannel blanket, fold it over to 3, and it's right under the middle of the sacrum. The fluoro is on the opposite side you're working on, and sometimes you're back and forth. So either the fluoro needs to change or you need to have 2 fluoros. You need the star frame set, which comes with just that big circular half bow and the cross clamps, and we'll look at that later. And you need a large external fixator set. That's going to give you your outriggers and other little bars and clamps and stuff you need. And then you need whatever hardware you're putting in the pelvis. So this is what a basic star frame set comes with. It comes with 2 rings, look like this, 4 clamps to attach it to the table, and a variety of crossbars that are designed both to stabilize those 2 rings to each other, side to side, and you'll see we're going to start to attach X-fix pins and other instruments onto those crossbars. You also need the additional traction bow setup for the OSI table, so we already have that on here. And then the carts will bring with it the actual outriggers for the traction, and we'll go over all that in real time. So we need the large X-fix set, and the only reason for that, and our sets have changed a little bit here, as you guys know, now all the bars are actually separate from the set, and we may be changing that back. But the reason you need the X-fix set is because you need more of those bar clamps and pin bar clamps, and you need some more bars to act as outriggers on the star frame. So these bar clamps are the only kind you can use, the ones that are open. You know, they come in 2 different varieties. They come open that just kind of snap on, and then they come in a closed tube. Well, of course, the closed tube for that contained ring doesn't work. You can't get it on, right? So they have to be these open bar clamps. And then typically we use 2 different kinds of pins that we have here. We've got it really narrowed down. So Star Frame makes a really long pin. These are designed for every size of patient, like the typical Texas size patient that has a huge soft tissue envelope. These are 500 millimeter pins. They're huge. So when you use those, you also need to have the big pin cutters, and they're 6 millimeter pins. And then we have some shorter ones as well that are also self-drilling. They're made by Stryker, very similar in thread length. They're the same diameter. They're also individually wrapped, they're just shorter. So we use those as well, depending on the indications and the patient size. The reduction tools that come with the Star Frame, we'll look at those as well. We call them the Rhino reduction tools just because of who they were developed by. And essentially all this is a push-pull device that attaches to that frame by this side clamp. And so there's a ball spike, there's a variety of hooks and elevators and things that you can attach onto the end of that chuck that will then be attached to the frame that can act to push and pull, and we'll see that in real time in a second here. And then we use a traction setup. So this is, again, we should take a new picture of the way we do it here. This is the traction bow they had, this big scooping one. But we just use the standard K-wire set with that U-shaped traction bow that we use for all other traction indication. And that's typically set up sterile. And then we dock that into the bed, into the traction device in the bed, unsterile, and then we drape over top of that. So I like to set the patient up, depending on the side of the injury, you may shift the patient slightly over towards the injured side if you're really only truly working on one side, but most often the patient's right in the middle of the table. You want to drape them as high up as you can. You got to be able to get right up to the crest. And the other thing you want to check every time before you set up is that you don't have a bunch of drapes or blankets or other stuff along the edge of the table, because over top of the drapes, those clamps are going to be attaching to the table. So the more stuff you have along that edge, the more likely it is those clamps will end up being loose. And then you want the patient's arms to be right out at 90 degrees if they can tolerate it, if they've got normal shoulders. And then we're going to put that start frame right up in their axilla. So you'll see me up here shifting up our boards to try and get those out of the way. So we're going to attach the frame with 4 clamps as high up in the axilla as possible, and we're going to try and make it even side to side. So one on either side of the bed. And then we're going to attach crossbars, both to stabilize, and we're going to start to think about where those pins are going to be coming out and start to try and put those crossbars in spots that we can actually attach them to the pins. So the first actual patient intervention is to stabilize the patient. So remember I was talking about, if we think just in general terms, one side of the pelvis is stable in this theoretical injury and one side is unstable. So we want to attach the stable side, thereby the remainder of the patient, to the bed. And the way we do that is using anchoring the patient with what we call well-sided pins or uninjured-sided pins. So we usually put those in a few spots. This one is showing what we call a supraacetabular pin, so that usually goes in right at the side of the patient here, right above the hip joint. And this is what it looks like sticking out of the patient. So you can see here, remember I was talking about outriggers, using that X-fix set to make outriggers. So sometimes you need to make a little additional bar on the outside of the frame, depending on where the pin comes out. Because you can see this pin hasn't come out right in line with any of the bars that are actually on the frame. So we've tinker-toyed another little setup on the side here to attach that bar, or to attach that pin. So the next thing we do then is we're going to put a second one in, and this one usually goes in, it's a position we call an LC2 position, going through the front of the pelvis here, right above the hip joint, but at about a 90-degree plane to the last one. And that's what this one looks like here, coming out the front. So now we've got this uninjured side of the pelvis is locked to that frame in 2 planes. So the patient is stuck to the frame, and the frame is stuck to the table. So the patient's not going anywhere. And again, you can see we've got crossbars in a position that we've tried to set it up so that we can catch this pin here. And then we've got a little outrigger there to catch the other pin. So now that we're anchored, what we're going to do depends on what pattern we're fixing. So it depends on that first diagram I showed you. Is the pelvis open like this? Is it vertically displaced like this? That will dictate what pins you need and whether you use traction to do the subsequent reduction. But essentially you do a sequential reduction. So you'll see we use 2 primary views. The C-arm is flipping down here for an inlet and over here for outlet, inlet, outlet, inlet, outlet. And we're doing a sequential reduction in several planes. So we can reduce it in one plane. So like, let's say the pelvis is sheared up like this and we're pulling it down in that direction, pulling down, 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 and we can lock it every time we pull. And then once we're happy where it is in that position, say we look at the other view and the pelvis is still shifted back, then we can use a pin in another plane to pull it forward, 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 forward. And again, locking it at every sketch. So the realignment is really controlled. And once we get it, we can lock it. So same as we've locked the well side of the pelvis to the frame, once we've actually got that reduction using those pins, we can lock that injured side to the frame as well. So then it's easy in a sense. We can take a breather. We can talk to the fellow about this is where we're going to put the screws. I can walk over to the floor and say, see, this is where I'm looking at the foramen. I want you a millimeter above here or a millimeter below here. Someone can come in and ask a question about the next case and nothing is moving. So it becomes very controlled. So you can see here, and this is from my fellowship, but these are the staff, this is the staff person here. So he's washing, his hands aren't even on the patient, right? And the fellow is putting in the fixation. So, the first thing, I'll just show you guys a few kind of technical shots, but what I was kind of trying to demonstrate with my hands there is how this works for the one plane, which is that in a vertical shear fracture, the pelvis wants to travel towards the head. And we can see by these little red lines, those two elements of the pelvis should be closer together. And they're shifted way up towards the head. And by pulling on the legs and using the reduction techniques I'll show you in a second, we can correct that really well. So the main way we correct that traveling towards the head is with that traction pin in the knee. So as I said, we usually put that in sterile. We put a pin across the distal femur and then dock it. You can see here they sterilize all these parts. Here we would be sterile up to here, and then this would be unsterile. So all of that would be covered with drapes. Another thing we can do is we can put a pin in the top of the pelvis up here, and that allows us to push that half of the pelvis down using the frame. And this is that push-pull device I was telling you. So when we attach this to the frame, again using a bar clamp for this sidebar of it, now we're even more controlled. So rather than grabbing that pin, with a T-handle or something with my hand, I can literally dial in the reduction by twisting this wheel, right? Because it's pushing this element along the threaded shaft of the push-pull device. So what we call coronal displacement, or displacement on that inlet view, which is what I was telling you when the pelvis often wants to travel towards the patient's back, and you can see by these little red marks here how much this pelvis wanted to travel towards the patient's back. Using a specific pin, we can pull that forward and correct the shape of the patient's pelvis. And that most often is done again with an LC2 pin, which we saw when we locked the patient to the pelvis, or to the frame. So here we are putting another pin on the other side, which we're going to use for pulling the patient's pelvis forward and be able to correct that posterior displacement. So the last part, this here is just showing what we call sagittal displacement, or opening of the pelvis, and that again can be corrected with push-pull device or even just with the screws through the frame. And we can see here a push-pull device attached to the side of the frame that's pushing on the back of the patient's pelvis and closing it. So there it is doing its job there. So, and then the last piece, which you guys know because you see here all the time, is that we just start putting fixation in the back of the pelvis. And the overwhelming majority of the time, that's just the standard cannulated screw sets that we have here in-house, the Synthes ones, 7.3 and 6.5, and oftentimes using the long screw cage for that. And then once we fix the back of the pelvis and we've got it exactly where we want it, and then oftentimes we're moving on to having to do something to fix the front of the pelvis. So the easiest one, and one that very often we end up using because these patients are usually the most injured, is just leaving those pins in that we put in for the frame. Leaving those on, maybe cutting them a bit shorter for ease of care and sitting, and attaching a frame across the front. And then the patient goes back to the ward or the ICU with that on. Or putting some kind of fixation in the front. Here we can see an anterior column screw or a screw in the front of the pelvis going in. Or also commonly using a symphysis plate to support the front of the symphysis. In which case you would remove the frame and everything off the table in order to be able to do that open part. Okay, so let's just go through one or two case examples, and then maybe we'll actually get the frame out and touch the pieces and kind of see how it attaches to the bed. So I'm just going to show you one case. So this is a young patient that has a badly injured pelvis. The reason it looks so squished in and kind of overlapped is because of this little shadow here, which is a pelvic binder, which often goes on in patients that are badly injured, that have a pelvis fracture, that are bleeding. First thing we do in the emergency department is put a binder on, close down the volume of the pelvis. So that's why that pelvis looks so squished. Left to its own devices, that pelvis is all over the map if we take that thing off. So this half of the pelvis, you can see from where the hip is, where the bottom of the pelvis, the ischium or bottom of the pelvis is there, is way high compared to the other side. So this is a vertical shear pelvis injury, and this is something that happens from a vertical shear type injury, so a fall from height and that sort of thing. So this is just a CT scan showing this. This is what a normal SI joint looks like. We can see this SI joint on the other side is completely disrupted, and that's what's allowed the patient's hemipelvis to travel so far. So we put a regular X-fix on to kind of try and control the position transiently, and you can see that doesn't do very much, right? This is a really bad injury. So the only way we're going to be able to hold that pelvis in the right ballpark is to do something definitive and put some fixation in the back. So we put 2 external fixator pins on the well side like we talked about. We've got one here, one coming out the front. We correct that displacement towards the head by using that traction pin and that iliac crest pin we talked about. We correct that displacement that's going back this way by pulling forward on the second pin that's coming out the front. And then we put 2 screws in the back. And so this is where this patient started, and this is where this patient ended. So you can see we've left these external fixator pins in, but that the hips are now at the right level, the ischium are now at the right level, and the SI joint at the back are at the right level. So that's all something that we can achieve without opening the patient's skin by using the frame. Okay? So why don't we move on to the more kind of nursing focused stuff, the less kind of x-ray technical part, and go through the pieces that we would actually get and use with us. Are we opening this one?
We don't need it.
Okay. So, so this thing takes up a lot of room, obviously, on your back table. So, this is what you're going to get, is 2 side mounts that are these half circles. And then, are you talking about this or right here?
It's over there.
Separate? And then the 3 cross guards.
Just open it for. Can you open it for her? Just
Here. Perfect. And obviously, as I'm sure you're all aware, we've got to be, when we're handling this stuff, we've got to be really careful. I'm always watching the fellows when they're putting this stuff on, thinking, don't drop it. Because we don't have, obviously, backup set for any of this stuff. So, first thing I would do, so this is always going to be over drapes. So you guys would hand up one of these clamps. There would be a fellow on the other side attaching at the same time. And we're going to drop this in. Now we gotta wait an hour to flash it. So that one actually doesn't attach. So these clamps, if you guys are ever doing the attachment part, have 2 tighteners on it. So this bottom one is what tightens it to the table, and the top one is what tightens onto the bar. So, sorry. And I often change my outer gloves after this part because it's sort of getting into the. And similarly, if we're taking this stuff off to do a second part of the procedure, like if we're doing a synthesis plating or something, we should probably hand them out directly because they're sort of borderline out of the field. Okay, so we've got this now attached to the bed, and we tighten it. And we can see, even when we tighten it, these still wobble a bit, right? They're only attached to the bottom. So, and we're going to exert a huge amount of force through this patient when we actually put the traction on. So that's why we attach these crossbars, which is going to make a huge difference in how stable this is. Sorry, toes. So we attach that there and do the same thing on this side. And we obviously don't have the wrenches open until we open the X-Fix set.
We have the non-sterile removal ones out in cord.
Yeah, can someone grab that? Okay, so once we get that tight, I'll show you guys, it's going to make a huge difference in how stable this is.
Doesn't matter if they have to be exactly even on the table.
Yeah, they should be close, yeah. It's not the end of the world, but they should be close, because otherwise the whole thing ends up being a little bit off. Things. Okay. So now this thing is attached to the bed. You can see it's shaking the whole bed now, right? But the patient isn't yet attached to the frame. So, patient's in the middle, frame's attached, but the patient's not attached to the frame. So, the next thing we're going to do, we won't actually probably open these ways, but we're going to attach the patient to the frame now. So, this is the 500 millimeter pin we were talking about. Most often I do use this one on the side pin, because this one can be too short depending on the patient's size. So we would make a small incision, the x-ray would be coming in, and we would buzz that pin in here. So once that pin though is sticking out to the side, you can see we don't really have the ability to attach that to the frame, right? It's sort of in a breeze. So in order to attach that to the frame, we're going to need to use the large X-Fix set, and we're going to build just like a little outrigger right at the right spot. So it's not going to be a bar this long, but say a bar up to where my hand is. And we're going to just attach a little outrigger there. It's going to then attach to the frame. So we're going to need 3 bar or pin bar clamps to do that, right? So this one then is going to be attached. The next thing we're going to do is use this shorter pin in the AIIS position. So it's going to go in right here, right? So again, we're going to use the x-ray, we're going to buzz that pin in. And once we've got that in, then that's when I'm going to start placing my second crossbar. Because ideally, I'm going to attach that directly to the crossbar, right? Without having to use any kind of additional bar or outrigger. So we've got that pin in there. So once we've got that pin in, I'm going to attach that crossbar here to hold that pin, okay? And as Lorraine pointed out, because the patient's not, or because I don't have the frame mounted perfectly evenly, you know, these are going a bit off kilter to the patient, which we could correct at this point by moving this up a little. Okay, so now we've got this crossbar attached, and that's got this pin on it. Okay, so this pin is locked here, and our big side pin sticking out here and is locked to an outrigger. So now this side of the patient is stuck to the frame. So we've got, so this is our uninjured side, and the left side is our injured side. So how our draping would look, just for the purposes of how we're going to dock this to use our traction, is that the draping would look like this, typically. So we can prep in both legs, but that is, you know, with the groin and stuff is a big ask, right? So we're gonna leave that leg totally free. We're gonna prep across the groin and down onto the bed like this, and then up. So we've got full access to the pelvis and access to the injured leg, okay? So now this side's totally locked. So the question is how we're gonna attach this side and what kind of pieces of equipment we need. So the next thing that we would do is typically now we would be ready to place the traction. So can we open that? So we would use one of these pins to go across the distal femur, and then we would attach the traction bow to it. Okay. So once we've got the traction bow attached, once it's actually attached to the distal femur, you know, when you pull on it, the knee's going to bend like this. So this is sterile, the leg is sterile, but what we're going to have to do now is try and dock it onto something unsterile. And that's always the tricky part of this procedure. So the pieces that we need for that, yeah. Okay, do you have one? This is patient's right. Do you have one? This is patient's left. There we go. So before we even start this, I would have come in and trialed all this with where the patient is on the bed before we prepped. So what length of bar we want, typically it's the shorter one, where the patient is up towards the head and down this way, on how tall they are, to make sure that all of this is set up properly and it's going to reach. Okay, so these bars come in several lengths, but usually it's going to be the shorter one we're going to use. We want to use as short as possible, because you can see we're now getting into a situation, especially in this long sitting room that we're always working in now, where we've got a big unsterile mass at the end of this table with other unsterile traction equipment and potentially a long bar coming out of here that's also unsterile. I'm standing up here with potentially having to have the x-ray on both sides. So most of your sterile setup is still down here, right? So we have to be really cognizant of this. Back. Turn this 20,000 times. So we would want to set this up with it in as little traction as possible. So pushed forward this way, because when we twisted the other direction is when it's going to be pulling traction. So do that. And then we're going to attach this. So these are the only pieces that work for this. So, and they're all marked on that card. So, this cable holder, they call it, that's got a pin that drops in directly through the hole on the traction bow. See this little pin here? So that's why they're all marked, because over time, like at times, we've lost each of these bits, and then there's really no other replacement for it. So similar to the setup we have for the fracture table when we're doing like tibias and stuff, is that it's got a slot that this slides into, and then we need to line up a central hole with it and be able to drop that pin in, okay? So all of this, we would have set up in advance, okay? And then once I've got the patient all draped and everything else is set up, I would become unsterile, because somebody that can actually dock this has to be unsterile in order to do it. And so either me or one of the fellows would become unsterile. And then this patient is a little far. Let's imagine that she's down like this. Could I actually have the one longer than this person? So this is why we would set it all up in advance, right? Would be to make sure we've got the right line. Okay. Tight. So we would want this to be a fairly straight line with that bar, okay? And then here we've got the, so let's back this up a little bit. So the fellow, someone is going to be holding this like this, okay? And they're sterile. And I am holding this end and I'm unsterile, okay? And I've got the pin facing upwards. So they're pulling this forward like this, and I am gonna pull, with that loose, I am gonna pull this back with the pin out until I can dock it. And then the only downside of this setup is that, contrary to how these pin attachments or attraction attachments work on the fracture table, is that pin doesn't actually drop through a hole on the other side. So we've got to get it goes through this shaft here, through the traction bow, and then docks on the bottom, but doesn't actually come through a hole on the other side that we can see. So this is always the trickiest part, is trying to see through the side here to see when you have successfully docked this thing into the hole. And it's got to be right through the hole. So it can be very hard to see, but I think I've got it. There we go. So when you get it, you see when I thought I had it there for a second, this pin wasn't going down. When you actually get it, all the threads on that pin disappear. Okay? So I've tried to do that without touching the traction bow, or at most touching the traction bow just on this threaded part of this distal part, leaving everything in the U sterile. So the minute we're done with that, we're going to, between the nurse and the fellow, or the resident, take a U-drape on the underside and cross it over top of here. You know, give it hopefully 5 centimeters of gray area there between where we know we've touched and what's sterile, to get it covered. And then we're gonna recover it a second time and then put a big drape over top. Okay? And then I'm gonna pull on this just to give it kind of some resting traction before we even start doing our reduction. And I'm gonna lock that, and then I'm gonna go and at minimum change my gown and my gloves. Okay? So the next thing that you guys would potentially be asked to do with this, then we would go back and start putting probably a second pin in here that's gonna attach to this crossbar at the same time. Okay? As a circulating nurse, the next thing you would be asked to do would be you want to know where all these bits are underneath the table, because there's a potential you would be asked to either bring this up or down to increase or decrease the knee flexion. Okay, because the higher this is, the more the patient's knee is flexing up, and the lower it is, the less the patient's knee is flexing. And then most importantly, or most likely, you're going to be asked to come over here and crank this thing to the right, which is going to pull this contraption towards the end of the bed, which is going to pull the patient's leg. So that's how we're going to use the traction to pull the patient's leg, which is going to pull the heavy pelvis down. Okay? Okay. So, and you can see, this is often going to have a big piece hanging off the end. So, the last thing we should look at here is these push-pull devices. And I'll show you by far the most kind of likely pieces we use. So all these are is a chuck, like you're gonna have on the end of a drill. And then it's got a long threaded component, okay, that allows us to push and pull the threaded component through the shaft there, which allows us to push and pull on pins or on other instruments that attach onto the end. Okay, so typically you would hand these pieces up separately. So this is just like a ball spike. I would say that would be the most common one to use. Well, that's not true. The most common reason to use this would be just to attach it to a next fix pin. So the way this works is that if we have a next fix pin, is that this outrigger or this side arm acts very much like a bar, right? So we can attach it just like we would a bar. So we attach this to the side, and let's say we attach this for argument's sake here. Okay. So I lost my wrench. See that unsterile wrench. Okay. So we would attach the push-pull device onto the frame or to one of the crossbars, and this chuck end would be attached typically onto either a next fix pin or one of those ball spikes. So we would tighten that on, and then the next thing we would ask for would be what I always call a Tommy bar, which is designed to go inside the tighteners of the push-pull device. And all that's going to allow us to do, so you can see, so if we imagine this is under a lot of tension, as I'm twisting this top one here, that is slowly pulling the device away from the patient, so would be pulling on that pin. And when it's under a ton of tension, you need to use the actual Tommy bar or the wrench to do so. But that's pulling the pin away from the patient, which is pulling their pelvis forward. And then once you get it where you want it, you would, again, lock it and not have to touch anything else. Okay? questions so far?
Would you ever just use a start frame alone without the traction?
Yes. So I would say a start frame, like, it's one of those things that's a big cumbersome setup. But when you actually, once you get it set up, it works really well for all kinds of pelvises. Like even, I don't know if anyone was in the room with Dr. Gee yesterday doing that pelvis where all they had to do was close the front. So if you wanted to go through a half an hour of setting this thing up and just had one pin on either side and did this and locked it to the frame, that works great for that pattern. But the truth is, in real time, it's a lot of setup and a lot of OR time for something that's not that complicated that maybe you don't need it for. So the most complicated ones that we are most likely to use this frame for are the ones that are vertically displaced. And for those, yes, you're always going to use the leg traction. So I would say, in reality, these two things are paired here about 80% of the time. But absolutely, there's lots of pelvic patterns that you can use the frame for that you don't need traction for. Any other questions, guys?
What if there's a low side?
Yeah, good question. So that makes it much harder to use the frame. So usually the way we would do that is we would fix the less injured side first through a mechanism either using the frame or not using the frame, and fix it stably enough at the back that it then sort of becomes a well side. Because it's only the most displaced side that you really need a strong post to pull against. So luckily it's rare to have both sides be all over the place. So it'll often be an 8 out of 10 entry on one side and a 3 out of 10 entry on the other. What else? So the only other piece of equipment we didn't open, but that I don't even, it's going to be changing so shortly, I'm not sure.
Which one?
The X-Fix set. So right now the X-Fix set, really the only reason we open it is because it's got more of these little clamps in it. But it doesn't have any pins in it right now that we use for this. All the pins are individually wrapped. And right now it doesn't actually have any bars like for outriggers and stuff. Those are all again individually wrapped on the panel on there. So I would be pre-selecting those and have a bunch of variety in the room to be ready. It sounds like they're likely moving back to a system where everything will be contained in a set, in which case absolutely you need a large X-Fix set. And this will work with either the Cindy's or one of the other companies. They're all the same size. Great.
That's very good.